Welcome to This Week in Health IT News, where we take a look at the news which will impact health IT. This is another field report where we talk with leaders from health systems and organizations on the front lines. My name is Bill Russell, healthcare CIO coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. Are you ready for this? We're going to do something a little different for our Tuesday Newsday show next week. We're going to go live at noon Eastern, 9 a.m. Pacific. We will be live on our YouTube channel with myself, Drexta Ford, Sue Shade, and David Muntz with Starbridge Advisors to discuss the new normal for health IT. With you supplying the questions with live chat. Also, you can send in your questions ahead of time at hello@thisweekinhealthit.com. I'm so excited to do this, and I hope you will join us. Mark your calendar, noon Eastern, 9 a.m. Pacific on April 28th. If you want to send the questions, feel free to do that. And you can get to the show by going to thisweekhealth.com/live. This episode and every episode since we started the COVID-19 series has been sponsored by Sirius Healthcare. They reached out to me to see how we might partner during this time, and that is how we've been able to support producing daily shows. Special thanks to Sirius for supporting the show's efforts during the crisis. Now, on to today's show. Today's conversation is with Dr. John Halamka, president of the Mayo Clinic Platform. Good morning, John. Welcome to the show.
Well, good morning. And glad we could do this with social distancing.
This is, we always do this show with social distancing. Well, except for at conferences, I guess. Thanks for taking the time. I know that you're busy. You've been working on this national COVID-19 coalition. What is the coalition, and what have you guys been doing?
Sure. So let me tell you how it started and what we're up to. So it was about 4 weeks ago, and I realized at about 5 in the morning that hundreds of companies were contacting me saying, what is the organizing principle by which we could collaborate, communicate, and convene? And it was just at that time I realized there wasn't an organization quite doing it. And so we decided that we would put a couple of folks who are willing together. MITRE Corporation agreed to serve as the program manager at no cost. And today we're at over 700 organizations participating. And we have 11 different work groups working on things from, what ventilators are needed where, of what type, what personal protective equipment can you trust, and how do we route it to places where it's needed? How do we collect data? Do anti-malarial drugs work? Do we have an idea if convalescent plasma is helpful or not? So we're helping support the National Convalescent Plasma Program, which now has over 1,000 sites. So organically growing thing of people just doing their help each other with no economics, right? No one pays anything. We're just helping each other.
That's great. So what is it? Is it a combination of pharma, government, providers? I mean, who's a part of it?
And so the answer is yes, all of the above. And so, for example, Google, Microsoft, and Amazon came in early. The entire University of California came in early. Rush. We have pharmaceutical companies. All of these folks, primarily private sector, right? It's a private sector driven initiative. And although we may have participants from government, it is not government sponsored.
Got it. All right. So the show is This Week in Health IT. And while I would enjoy talking a ton about, reopening the country and ramifications in those, I'll let CNBC and the rest of those guys really handle that one. What I'd like to talk about is, things like data-driven outcomes, contact tracing, and platforms, and just see where this goes. So let's start with data-driven outcomes. So, what does the clinical care data set look like that the coalition's looking at, that the CDC is looking at, that researchers and public health officials are looking at? Have we been able to pull that clinical care data set together?
So let me answer this in a couple of ways, which is, suppose that we wanted to get together 200 Epic and Cerner using organizations to ask a question like anti-malarial drug efficacy or convalescent plasma side effects or such. Can you imagine, and I'm not talking policy or technology, I'm talking psychiatry, of what it would take to get 200 disparate organizations to contribute really comprehensive data sets to a central repository run by anyone in the short term. The answer is, you can do it eventually, right? Registries may be the answer eventually. You're not going to do it tomorrow. So here's what we did. We went to the EHR vendors, and they were incredibly helpful. They said, you know what? Because each of our EHRs, although standards compliant, still has different ontologies, right? The way we name a field, the data we record, that sort of thing. So how about this? We'll define numerators and denominators comprehensively for any of the measures you want, for Epic, for Cerner, for Allscripts, et cetera. And then we will build those scripts at our customer sites. So the customer can now run it against their live data and report the numerators and denominators, which are by sort of definition aggregated, de-identified, don't fall into any regulatory framework. And that has worked amazingly well. So what I'll call is like near real-time capacity to do cross-organizational analytics. All that's running over the next couple of days on the areas that I describe, anti-malarials and the use of convalescent plasma.
That's amazing. I guess it's an appropriate question from a privacy standpoint. You're just getting analytics back, right? You're not getting there's no records moving around.
Right. So if you were to ask Epic, do you own your customers' data? They would say, well, no, right? We're a software company, and although they might have a cloud hosting service, most of the Epic instances are locally run. So what you would say is, even if Epic wanted to run analytics across every one of its sites, it just really can't. I mean, that's just not the way the data is distributed. But to write the queries in Epic so that each customer could then run the numerators and denominators and share them, of course they can do that. So this is a federated analytic approach that really gets beyond a lot of the logistics and data use agreements and that sort of thing to create a registry.
Will we see that? Will you see that expand to like Meditech and others?
I have every expectation that this is going to expand because there are really two ways we know to do analytics. One is that you create a federal certification requirement where every EHR vendor submits an HL7 V2 or a US CDI payload to a place, right? That could be the CDC, or it could be, some industry-based registry. I mean, that's one way to do it. The challenge with that is sometimes that's identified data, and right, it runs into a lot of interesting issues on how data is used, who can look at it, and how you protect it. Whereas this federated approach leaves the data within the firewall of every organization, and everybody feels pretty comfortable about doing that kind of thing.
Yeah, it does. It's a pretty elegant solution, actually. But not to get too far ahead of ourselves, but coming out of this, is this going to be the way we sort of design this for future pandemics, or are there other things we're thinking about in terms of the data and how to respond a lot quicker than we did for this one?
Well, sure. So that's just one use case. We're asking, you said data-driven outcomes, right? So that's an outcome. But wouldn't you like to know, here it is, April 21st, how many ventilators are going to be needed in Florida 2 weeks from today? How many are in use right now? What's the delta, right? Challenge with that is, do you have any idea how the CDC is collecting this information?
I assume it's like little strokes of pencil on a paper.
You got it, and then you hand type it into Excel and email it, right? As opposed to Keith Boone, Audacious Inquiry, HL7, Chuck Jaffe, they're working on a FHIR situational awareness standard by which there's just an API sitting on your EHR that says, how many people are in the ICU on ventilators now? 12. Right? I mean, it's no spreadsheets or smoke signals or Morse code here. And so it seems to me that if we are going to be ready for the pandemics of the future, not only do we need all the outcome stuff we talked about, federated query, but we need situational awareness APIs using FHIR that enables our public health entities to say, whether it's how many are immunized, how many ventilators do we need, what PPE do you need, all this stuff is not that hard to automate if you have a standard.
Yeah, and it's interesting because we're not experiencing this pandemic all at once. We're experiencing it; it's sort of rolling around the country. So we probably have enough ventilators, but if they're in the wrong location, it doesn't do anyone any good. And so a Fire API is also kind of an elegant solution for determining where that is and getting that stuff moved around the country, I would think.
Well, as well, you have to recognize that this is a very unevenly distributed infection, right? And so that is, you might very well today have few infections in Iowa and lots in Boston, but wait 2 weeks. And so what you're going to need to do is put together the modeling of the epidemiology with the personal protective equipment and ventilator and staff capacity and begin to shift resources. A great author once said, famines don't exist because of a lack of food, but a lack of a distribution of the food, right? And I think we're seeing actually the same thing with personal protective equipment and ventilators right now. And this fire approach is something we'll learn a lot about in the next few weeks.
This might sound like a self-congratulatory thing for the industry, but could you imagine going through this pandemic without an electronic medical record across the board, which we started, a decade or a decade and a half ago? I can't imagine where we would be.
Well, I know exactly right. And so people say, oh, the EHR, of course, has had a burden, which it has. The challenge has been in the past, we haven't returned anything to our clinicians from the EHR. They put data in, they didn't get much out. And now the ability to say, oh, well, now that we've put this data in, we're going to get coordination of care and supplies and learning and cures. Aha, there's a benefit finally at the end of the rainbow.
All right, so let's start talking digital tools. And I want to start with contact tracing. We know that Apple and Google are working on solutions. Are there solutions that individual health systems can implement or are trying to implement?
Well, so let's talk about the multiple approaches that have been used. So MIT at the Media Lab with Mayo and MGH working together, this was about a month ago, created a GPS tracker. And here's how it works. Basically, you consent and you say, I actually would like to track my location so that if there is someone I cross who's positive, I can submit my GPS tracing over the last month to a registry at Public Health and see if there was crossover. So, and that's great, but it has one challenge. You said you're in Naples, Florida. Well, your GPS would have your home location in your GPS data. That's not exactly de-identified, right? So you'd have to then, as a public health department, sort of redact an individual's submission, maybe the place they work or the place they live, or something that would be truly identifying to them. So what Apple and Google have done is really interesting. Would you agree that if you want to do contact tracing, you would simply turn on your Bluetooth function on your phone, and a API would be available to public health from your phone that does nothing more than collect the Bluetooth signatures of the people within 6 feet of you, right? So it's not identified. And in fact, the global universal identifier for the Bluetooth is actually changed quite frequently, so that there's really no mechanism of hacking and figuring out people's movements and that kind of thing. No GPS signal. This is just to say, who have you been close to? At which point then, when a phone is identified as being a COVID positive person, anyone who was near that phone could be notified. So it's really kind of an elegant privacy protecting way of doing contact tracing.
Yeah, that's interesting. I mean, would there be a situation where a health system would try to do this lift, or essentially, I mean, is there a need within a care delivery platform to have this kind of mechanism, or would you just tap into Google or Apple's solution?
Yeah, I mean, the challenge is that your contacts are bigger than any one health system. Right. And so I think the answer is that many of us will want to contribute to these contact tracing efforts by providing clinical expertise, privacy oversight, maybe even create some novel apps. And we're working on some novel apps to help with return to work and things like that. But it's truly got to be a national scale effort.
So, what other digital tools have you seen be effective during the pandemic?
Well, and so I mean, there's a couple of threads that I want to work on here. Um, Mayo has recently released what's called Mayo Expert Advisor, which is traditionally a tool that is not available to the public. We're putting it now in a place where all physicians in the country can access it, and soon even the public will be able to access it. And it provides accurate advice. So here's a problem. Do you think eating twice your body weight in garlic is going to help your COVID resistance? Well, there are websites that suggest it.
Well, John, obviously it's going to, because it will keep people away from you, I would assume.
Well, there you go. But so the point being is that part of the apps have got to be just getting rid of the misinformation.
Right.
Right? So a lot of us working on just getting the right information out, getting the data out. If you go to the website of the COVID Coalition, there are over 700 publicly available data sets on that website and data visualizations that anyone can access. There's no password needed at all. And so I'll get you the website before we finish. But it's situational awareness, it's knowledge and getting rid of misinformation. And then, of course, I think there are a number of interesting apps that are being deployed. There's a nonprofit in Seattle called Audere, Audere, funded by the Gates Foundation. And their app says, what are your signs and symptoms? It does a screening to determine if you need to be tested, and then if you need to be tested, arranges for you to be tested. And so figuring out who needs a PCR molecular test. As we get past the infection and get into return to work, then there's a question of tracking the serological tests. Immunize, do you have IgG? Do you have demonstrated resistance? Because you could imagine that we'll open the economy by bringing people who have already had it and recovered back to the workplace first, assuming that they're immune.
Yeah, absolutely. All right, so let's talk platforms. And if we have any more time, I mean, I've got like 75 million questions, but from a platform standpoint, so you're the president of Platforms now, which is a great title. Platforms help us to move quicker within a crisis or outside of a crisis, because key components are already stood up, and access to the data, security, it's already baked into platforms. So you can really focus in on the problem at hand. How have you seen platforms, or even the absence of platforms, come into play during this pandemic?
So a number of us have just completed an article which has been submitted. We hope it gets published soon in the scientific literature. That says we're going to look at the medical record of every COVID positive patient that has been tested in our organizations. And we're actually going to start to look at characteristics about them. Who had a severe infection? What were the earliest signs? Can you predict severity based on early signs? Well, imagine this. Suppose you wanted to go do a study that required you to access 20,000 medical records and do a comprehensive analysis. How long is that going to take you? Well, we did it in a week. And that's because we had a mechanism in place to de-identify data, place it in a container where then we could bring analytic tools into that container, run the analyses, and not share the data, but exfiltrate the knowledge. Right? And so this is what the idea of a platform does. It creates these reusable components and modules, these processes and these policies that enable you to do this stuff just really fast without having to relitigate with teams of lawyers the process from the very beginning every time.
Yeah, you talked about that at the JPM conference, and we'll probably come back and talk more about that as we go forward. As sort of a set of closing questions, talk to me about testing. I know I'm going to get outside of health IT here, but I'm more curious than anything. How much testing do we need? We have obviously the molecular testing, which is pretty quick to determine if you have it. We have the antibody test, which it looks like it's going to start ramping up if the releases from Abbott, the press releases and things, hold true, which is 20 to 30 million tests a month coming forward. I mean, what is an adequate amount of testing to get us moving back into this?
And as you might guess, there are many models here, which Amazon's model is that they think in order to get the Amazon supply chain back, that you probably read about in Jeff Bezos' blog about this, that they need to really do very rigorous testing of each of their employees on a regular basis. I mean, this could be hundreds of thousands of tests a week just to keep that workplace safe. And that's not actually so different to what some countries have done, kind of aggressive testing and contact tracing and that kind of thing. I think our challenge at the moment is we just don't have easy access to either the molecular testing or the serologic testing in the numbers that are needed for diagnosis and return to work. So you may have seen, again, we're not getting into politics here, but the Senate Health Committee last evening just put together a rider on the new, what we'll call sort of Paycheck Protection Program successor bill for $25 billion to just be routed to get us the adequate number of these PCR and serological testings wherever they are needed to get people diagnosed and the economy back on its feet. And the number is $25 billion needed to really ramp up our testing capacity. Because just look at the number of tests we can do every day today. It is a small fraction of what is needed. And so the models are varied, but it's still a small fraction.
That's interesting. Well, John, again, thanks for taking the time. I really appreciate it. I know you're on Zoom calls probably from like 6 a.m. till 6 p.m. every day?
That would be a short day. So for the last 4 weeks, I've been averaging 18 to 20 hours a day. And, but yeah, it's a once in a lifetime opportunity for us to do good here.
Yeah. So if Zoom were smart, they'd offer frequent flyer programs, and they could replace all the miles you were putting on airplanes, I guess.
Well, that's great. Now, one thing I just want to leave you with is the website for the coalition, https://c19hcc.org. https://c19hcc.org. And it's all free and it's all open source. In the resource library, you'll find hundreds of great data visualizations and training and all kinds of coalition-based resources.
Fantastic. John, thanks again for your time. I really appreciate it and look forward to having you back on the show. We'll get an update in a little bit.
Well, great. You have a wonderful day.
Thanks. Take care.
That's all for this show. Special thanks to our channel sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, and Pro Talent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send an email, DM, whatever you do. You can also follow us on social media, subscribe to our YouTube channel. There's a lot of different ways you can support us, but sharing it with a peer is the best. Please check back often, as we will be dropping many more shows until we flatten the curve across the country. Thanks for listening. That's all for now.